What's up, Ninja Nerds? In this video today, we're going to be talking about laryngeal infections. And again, this is a part of our clinical medicine series. And if you guys are really digging it, it's helping you, it makes sense, please support us. You can do that by hitting the like button. You can comment down in the comment section. You can subscribe. Also, I really suggest if you guys go down in the description box below, we got a link that goes to our website. On our website, I'm telling you, we got some really cool notes, illustrations, we got quiz questions, we're developing flashcards. Go check it out. I just think all of these things are helpful for you to truly master these topics. And if you want to take that chance, go check it out on our website. All right, without further ado, let's get into laryngeal infections. With laryngeal infections, you're probably like, okay, what are we exactly talking about? It's really a couple different types of diseases. And what I'm going to really focus on is epiglottitis. That's going to be one. The second one is going to be Laryngotracheobronchitis. Oftentimes we call it Croup. All right. We'll talk about another one called laryngitis, and that's really just sprinkled in there because it's not really the most common one that I want you guys to think about for the exam, because it doesn't have to be infectious in etiology, and we'll talk about that. There could be other reasons for it. But then afterwards, we'll talk about some complications, really hitting on something called bacterial tracheitis. We'll talk about airway obstructions symptoms, and then we'll get into this like feared thing called post-obstructive pulmonary edema. So let's dig into this. Before we talk about each one of these infections, I just have to briefly, and I mean briefly, go through the pertinent anatomy. And really what I want to do is I want to divide the larynx into three different subdivisions. So I'm going to look at this in a couple different sections. A sagittal section, meaning I'm taking myself, cutting myself like this and viewing from a lateral view. Cross section, coming right through here at that glottic level and taking a look here. And then a coronal section, slicing myself like this. And then generally what I'm going to be doing is, imagine someone's behind me and they're looking at that section from the back, the posterior view. So these are the three sections. The sagittal section, what I want to do is, I'm going to take, let's use this orange marker. And what we're going to do is, there's what's called, you have here, there's like a little bump. It's called they have two names. One is we call them the vestibular folds. Another name for it is we call it the false vocal cords. The ones below are called your vocal folds. Another name for it is called the true vocal cords. There's technically a potential space between the two vocal folds because you're only seeing the one side. So what I'm going to do is, I'm going to have a dotted line kind of going right here. And then I'm going to have another one right here. And then I'm going to have another one right here. And what I do is I effectively break the larynx up into three kind of divisions. One of these, right, is this portion here, right? And this one, we're going to just have it as one. All right, this is going to be the first component. This first component here is called the supraglottis. Again, what is it called? It is called the supraglottis because what I'm using, or we're going to call it the supraglottic, let's call it the supraglottic level, all right? Supraglottic level. So this is going to be the first component. And really what it is we're taking this dotted line here and we're doing it at the glottis, which is again, this kind of space between the true vocal cords. All right, so obviously above is the supraglottic level. All right, and we are very smart individuals, so obviously above the glottis is the supraglottis. So what would you call things that are below the glottis? You got it, I know you said it. It's the infraglottic, right? So the infraglottic level. But before we do that, we're going to talk about what are the structures that are at the glottic level. So we have the glottic level. And then we have a third component here, which we'll talk about, obviously, which is the infraglottic level. So we got supraglottic level, we have the glottic level, and then we have the infraglottic level. The whole point of this is that we're going to set the stage to talk about laryngeal infections very nicely. So the supraglottic level primarily, and we're going to get this from different views, the supraglottic level, but it's just best seen here, consists of what things? Well, you see this big flappy thing? What is this big flappy thing? That's the most important component. It is called the epiglottis. So what is that called? It is called the epiglottis. The epiglottis is essentially the most important structure in the supraglottic area. It's made up of elastic cartilage. What happens is when food and fluids come this way, we want them to go into the esophagus. So what should this thing do? Boop, block off the laryngeal inlet. That's its job. Another thing here is you can see these like folds. There's a fold here, and then there's a fold here. We're not gonna go too crazy on them, but they are a couple different folds. And so what I'll do is I'll put some folds, and there are two of them. One is called the vestibular, and the other one, if you really wanna know, is called the epiglottic fold. All right. The reason why I'm telling you all these things, epiglottic, so here, we'll just have that because we already talked about it. So epiglottic. So these are the two folds. So when we talk about the supraglottic level, the primary structure is the epiglottis, and then we technically have these folds. There's a fold right here, and there's a fold going here, and that's called your vestibular fold right here, and the epiglottic fold here, and this whole thing is called the epiglottis. At the glottic level, I told you the glottis is technically a space between the true vocal cords. So what's the primary component? What is the primary component at the glottic level? It's really going to be the vocal cords, which we also call the vocal folds. All right, so we'll call them the vocal cords, and these are technically the true vocal cords. And then at the infraglottic level, we really just have it's really just the structures that are below that. So really it's just, if you have here below the glottic level, you have the cricoid cartilage, and then you get into what's called these annular rings of the trachea. All of this is really what we're talking about. So it's just going to be the structures, or the cavity is really what I want you guys to know, that's below the glottis. So what I'm going to do for right now is I'm just going to call this the infraglottic cavity. That's all I really want you to know. All right, and really we're going to focus on the mucosa here. So it's really going to be the infraglottic cavity. All right, so that is the three components that I really want you guys to know, all right? So 1, 2, and 3. All right, if we take only particularly a cross section at that glottic level, this is what you get. And again, it's just giving you another view. The reason why this view is super important, I like this view because it's good for like function. It helps me to understand things like if something happens with the epiglottis, if there's some kind of inflammation here, particularly of that infraglottic cavity. The cross section is great because you know when you go to intubate somebody and you use the laryngoscope and you pull up and you take a look down, this is what you're gonna see. You're gonna get a view of something like this. So what we have here is we have a couple different things, but really I only want to focus on really just 3 primary things. And it's going to be this one here first, so 1, then it's going to be 2, which is really, when I actually do this, I'm going to do it like this actually. I'm going to do 2, which is this part here, and then we have 3. All right, so 1 is going to be the epiglottis. Right? So the epiglottis is, again, it's kind of just, if you could imagine, it's supposed to generally kind of cover over that glottic opening so that we don't get kind of foods and fluids to pop into it. So it's supposed to bend over, right? So that is the epiglottis. Whenever that thing becomes super beefy and angry and mean, you can kind of see how it starts to potentially flop over this area and cause a ball valve effect of that glottic opening. So epiglottis. The second component here is really, this is the best view of your vocal cords. That's really the best view of the, what are they called? The vocal cords. And which ones particularly? The true ones. So these are technically the vocal cords, and these are your true vocal cords. The space between here, all of this, which I'm going to represent, let's do this in brown. This space here, which I'm going to kind of shade in, is called the glottis. That's the space where air flows between, either in or out. The space maybe over here on the sides in orange, these are called your vestibular folds, which are your false vocal cords. These are the false vocal cords, okay? So we have true vocal cords 2, 3. Technically, if you get it at a specific slice, you may get 2 different types of cartilage. I just want you to know that you're going to have some cartilage here, and really it depends upon the level. And so, for example, the primary one that I want you guys to remember here is called the arytenoid. The arytenoid cartilage. All right? The reason why is, how do we connect the epiglottis to the arytenoid cartilage? The epiglottic folds. So again, the whole point of talking about this is because this is just another view that we can see of some pertinent structures that are critical to the larynx. This one, really good for seeing when things go wrong with epiglottitis. This one, you can really appreciate that if I were to go down and take a look at the vocal cords and see if there was something going on with the vocal cords, that would probably give me the best view. This one, the coronal section, we can see a lot of the same things here. We can actually appreciate it. This one is even better. You see how technically this is your true vocal cords right here. This little boop with the muscle coming into it, boop, muscle coming into it. So really what I want to do is this is the glottis. So right here is my glottic level. So then above and below, right? So here would be the supraglottis, and here would be the infraglottic area. So again, I'm just going off of the same thing, but I don't have to write it down here. This is 1, this is the supraglottic level. 2, this is the glottic level. 3, this is the infraglottic level. The beauty of looking at this view is because when we have individuals who have something called Laryngotracheobronchitis and we get different types of x-rays, we can appreciate this kind of swelling in the anterior version. We'll talk about something called the steeple sign. And so that's one of the benefits here. But if you take a look here, again, you'll see here's the hyoid bone at the top. Here's your thyroid cartilage. Then you have a ligament here between the thyroid and the cricoid cartilage. And then you have the tracheal rings, right? And then you obviously have these like little annular ligaments here. These are your true vocal cords. What's that space called? Come on. The glottis. This is actually called the laryngeal ventricle. These are called your false vocal cords or your vestibular folds. And this little bumpy up there is called the epiglottis. So this is just giving you another view of what we just talked about over here. Now, the reason why I took you through all of this is because, again, I think this is the best view for epiglottitis. This is a really good view for someone who has what's called laryngitis or something going on with their vocal cords. And this one's really good for laryngotracheobronchitis. Let's come down and talk about this. So when we have a person who develops something called epiglottitis, the definition of it is actually pretty straightforward. It's not anything crazy. It's inflammation of the epiglottis, right? So inflammation of the epiglottis, and you're going to get a very, very simple thing here. Epiglottitis is really primarily inflammation of the epiglottis. But if we really wanted to be specific, it would involve other structures. So again, it's at the supraglottic level. And so when I talk about inflammation here, really what I'm saying is this is all going to be the epiglottis, which is this flap here. This is all going to be super angry. But the other component here is that the other thing, this is all mucosa that's covering it. All this is mucosa. What was this called? The area epiglottic folds. So technically the area epiglottic folds are inflamed. And then as you kind of go down further, you get into what's called the vestibular folds. All of that is really technically inflamed in epiglottitis because it's all supraglottic inflammation. That's the key thing there. Laryngitis is really inflammation of what structures? Well, it's really these little guys right here that are getting kind of beefy and angry and swollen. What are those called? Those are called your vocal cords, your vocal folds. So whenever a person has laryngitis, the primary area that they develop inflammation of is really these guys, which is inflammation of primarily the structures at the glottic level. And what are those structures at the glottic level that I talked to you guys about? The true vocal cords. So it's primarily inflammation. The most common area is inflammation of the true vocal cords. All right. Then we talk about laryngotracheobronchitis. Again, we divided it into the supraglottis, which is again above the actual glottis, and then infraglottic. Well, really, this is the area that I care about because I'm going to go right here and I'm going to go below. So whenever a person develops laryngotracheobronchitis, it's primarily going to be some degree of inflammation of the infraglottic tissue. This is where we're going to see it. So inflammation of the infraglottic area. So again, remember we talked about this, we broke it up into 3 parts. I'll do it again one more time. Right here, bop, bop, and we go number system here. This was supraglottic, right? This was supraglottic area, which we already talked about. This was the glottic level, and then here is the infraglottic. It's going to be primarily inflammation of the subglottic area. So we'll put inflammation of subglottic, and technically it's primarily the mucosa, subglottic mucosa, which is the inner lining, that inner lining of pseudostratified ciliated columnar epithelial tissue. So we get the point here that whenever we're talking about laryngeal infections, it's really critical to divvy up the larynx into three levels: the supraglottic, the glottic, and the infraglottic. Epiglottitis is inflammation of the supraglottic tissues, the epiglottis, the epiglottic folds, and technically the vestibular folds. Laryngitis is primarily inflammation at the glottic level, which is the true vocal cords. And Laryngotracheobronchitis is inflammation of the subglottic mucosa. So now that we got a pretty good understanding of all of these different types of infections and their basic definitions, we should be able to move on to the first one and dig into it in a lot of detail, I would say. So let's focus on probably the most concerning one, the scariest one, the one that'll get you, and that's epiglottitis. So we know the definition, we know the particular pertinent anatomy, so we know it's involving the supraglottic tissues, epiglottis, epiglottic folds, vestibular folds. We know that it's inflammation of that structure. And what we know about this is that it is oftentimes a pretty serious type of infection. Well, what causes it? Well, it kind of depends. Based upon a particular timeline, we have seen in the past that it used to be primarily due to a very specific bacteria called Haemophilus influenza. Type B, which we oftentimes write as HIB, right? So Haemophilus influenza type B, that used to be the primary type of pathogen that we would see associated with this. What happened though is that there was an introduction. So the first component, usually I'd say pre-vaccine era used to be Haemophilus influenza. Then around the time whenever we started introducing the HIB vaccine, we noticed a significant reduction. And then what happened is, since the Haemophilus influenza was actually being prevented against with the vaccine, we noticed another pathogen started to pop up. What's that particular pathogen? This is usually, clusters of bacteria, and usually in a chain. So the primarily ones was usually what's called Staphylococcus aureus, or some type of Streptococcus species. And usually it was like Streptococcus pyogenes would be one potential one. So Streptococcus. So this is what we started to notice, is that over time, the type of pathogen has changed, but the exams still like to focus on Haemophilus influenza. And oftentimes when we treat these patients, we treat them with something called ceftriaxone, which is a particular IV antibiotic, and it's going to cover both of these. It'll cover your Staph aureus. It won't cover MRSA. If you do get MRSA, you'd have to extend it to something like vancomycin. But it'll cover most of your Streptococcus species. It'll cover methicillin-sensitive Staph aureus, and it'll cover that HIB, and that's really, really important. Now, when we talk about this type of infection, and again, we're going to focus on you get a pathogen exposure. What actually happens to the epiglottis? Well, again, let's say here we have our epiglottis, all right? And we're just using this functional diagram, all right? Using this functional diagram here. Here we have the epiglottis. So what happens is a person gets some type of pathogen exposure, whether this is Haemophilus influenza, whether this is some type of Staphylococcus aureus, or whether this is some type of Streptococcus species. Whenever they get infected, this is going to cause inflammation of the mucosal tissue. And that is the key thing here. So we're going to have, the first thing is we're going to have an infection of epiglottis. All right? Now, once you have this kind of infection kind of come in, how would you actually get these? How would you get these? Well, generally Haemophilus influenza type B, this can be a part of our flora, right? Sometimes it can even be a particular exposure, but generally it can be a part of our flora. And what happens is this thing is going to go in, it's going to hop, and it's going to start causing some damage. So that's what we're going to see, is this thing is going to start causing some type of tissue destruction of the epiglottis. Now with that tissue destruction, that's when we move on to the second point, which is then this dang thing gets super, super angry. So then what ends up happening is you get cellulitis, which is inflammation, and it's going to cause significant enlargement. So you're going to get cellulitis, and you're going to get a significant amount of enlargement of the epiglottis. Now that begs a really kind of quick divergent and talking point here. When I get cellulitis and a lot of enlargement of the epiglottis, this thing is going to become super enlarged here. Look at this thing. It's gargantuous now. And because of this, this thing is super angry. It's swollen, it's red, it's hot, it's beefy. Why is this such a big deal? Well, again, what was the primary function? If we go back to the epiglottis, what was the primary function of this thing? It's supposed to do what? Whenever food and fluids come down, it wants to direct it into the esophagus, right? So whenever a person gets inflammation, again, what are we talking about? Here is the, what is this called? This is the elastic cartilage. That's primarily what it's made up of. So the primary makeup, what I really want you to know here is you're going to have something called elastic cartilage. And that's what makes this thing really bendy, right? So this is called, it's made up of primarily elastic cartilage. That's the primary makeup. And then all of this black tissue kind of covering it is the mucosa. So whenever a person gets infected, you damage the mucosa. That causes a lot of inflammation, enlargement of that tissue. But the elastic cartilage is what gives it that bendy structure. Whenever a person gets inflammation, here's the thing that I want you guys to know. That epiglottis starts kind of leaning naturally. And whenever you take a breath in, guess what it does? Whenever you want to take a breath in, your intrathoracic pressure drops and you want to suck air going into the larynx. Well, that air is going to rush against the epiglottis and it's going to push it. And when it pushes it, it's going to push it just a little bit enough to block off the laryngeal inlet. And that's going to cause some pretty scary kinds of presentations. So let's talk about that. So whenever you have a person here who ends up having epiglottitis, there's a couple different ways I want you to remember how they'll present, okay? So we have cellulitis, enlargement of the epiglottis. When this happens, the first thing I want you to remember is the 4 Ds of epiglottitis. When this thing is super, super swollen and angry, it is innervated by different types of cranial nerves. Do you guys remember some of the cranial nerves that supply a lot of these areas here? We have them supply here. It even can come and supply these areas, and it really can supply this area. And really, this is a really, really important nerve. What's that nerve called? Cranial nerve 10, also known as the vagus. And there's even the glossopharyngeal nerve that also is critical here too, but cranial nerve 10, which is your vagus nerve, is really, really important. And what happens is when you get inflammation of this tissue, it sends signals down the vagus nerve. And what's going to happen is this thing is going to send a lot of signals down the sensory fibers of the vagus nerve, which is going to trigger what? A lot of pain. And so the response that comes out of this is that technically this will then send signals. It'll send signals to your actual central nervous system, right? So really what I would need to do is I'll have here kind of a structure here, the brain, and really the brain stem. And really that's where this is kind of going, is it's going to go and send signals up to your actual brainstem, and obviously this will kind of help with the process of what? This may lead to the presence of pain, right? So you'll get that conscious sensation of pain. Now here's the problem with this. That pain could be at rest, but the time that it gets really, really bad is whenever you try to swallow, right? You try to swallow any kind of fluids, your normal secretions, that pain is terrible. And that is often we define particularly as odynophagia. But for right now, to make this work, we're going to say this is dysphagia, which is difficulty with swallowing. But primarily, it's just a lot of pain with swallowing. That's really the particular nuance that I want you guys to understand. So whenever a person tries to swallow, that food and fluids, whenever it hits the inflamed, irritated epiglottis, it's going to cause a ton of pain. Now, because of that, whenever you have pain from swallowing, what's that going to do? It's going to make you not really want to swallow anything at all. And so what happens is you end up not being able to swallow some of your normal salivary secretions. And this basically leads to drooling. And this is due to pain with swallowing. It kind of just hinders you, and you kind of are reminded subconsciously that if I do try to swallow some of these secretions, it's gonna hurt like heck, and I don't wanna do that. So again, big thing that I need you guys to remember here is the patient will develop dysphagia. That's the first primary type of symptom manifestation. That dysphagia, which really, if we wanted to be particular, if we wanted to be kind of nuanced here, this dysphagia is kind of a misnomer. It's technically, if we really wanted to be specific, it's more specifically what's called odynophagia, which is that pain with swallowing. All right, so if we really wanted to be a little bit more particular, we should really kind of, this is more of a misnomer, but it helps with the actual overall kind of like mnemonic here, that it really should be odynophagia as compared to dysphagia. And that's causing that pain with swallowing. And whenever you have pain with swallowing, you don't want to swallow any of your secretions. And so you cause pooling up of secretions within the oral cavity. The next thing is, whenever you have this big, beefy, angry, and swollen epiglottis, not only is it super painful to swallow, but it's also going to be really difficult whenever sound is being produced. So whenever air is coming up through the lungs, right? It's supposed to move across the vocal cords, which causes vibration. That kind of changes the sound, and then generally what's supposed to happen is it's supposed to run through here and produce all of this different types of resonance, and then it runs through here, and then it produces different resonance right here. And obviously what you get out of this is a proper resonance of speech. Right? So this is going to cause the resonance of speech. Well, whenever you have a person here with an angry and inflamed old big fat epiglottis, that resonance is going to be affected. So now the epiglottis is causing a change in that resonance, and that's going to cause the resonance to decrease. And what this does is this causes a change in their speech. And really, what we would define this as is more of a dysphonia, so an abnormal kind of production of speech. And the way that they love to describe this in the exams is a muffled, or what we call hot potato voice. So that is something that you'd want to see. So a person who has epiglottitis, often due to Hib, pre-vaccine era, now more often than not, Staph aureus strep, you get inflammation of the epiglottis, it gets cellulitic, it gets enlarged, it starts to ball valve and close off the laryngeal inlet, especially during breathing. Because it's inflamed and it's innervated by cranial nerves, especially vagus, maybe even glossopharyngeal, that's picked up by those sensory fibers, especially when food and fluid comes into contact with it. And that causes a ton of pain when swallowing. They don't want to swallow, they accumulate a lot of their secretions, they drool, they have a lot of pooling up of secretions. Another thing is because of the resonance of speech being blocked by this big fat beefy epiglottis, they sound like they're talking with a hot potato in their mouth. But here's the most concerning feature. The most concerning feature is the concept of a dynamic obstruction. And I like to say dynamic obstruction because the dynamic obstruction is what can potentially cause the distress. So the dynamic obstruction is really what can precipitate the respiratory distress. So again, the dynamic obstruction will cause the distress. Let me explain, but we're going to go into this more when we get into the complication section. So one of the things here is that when you have this big, beefy, and angry and swollen epiglottis, whenever you take a deep breath in, what does this do? So whenever you take a deep breath in, right, you want air to flow through here and to be able to make its way into the laryngeal inlet, right? You want it to be able to make its way into the laryngeal inlet and down into the lungs. Well, during inspiration, what happens is, so inspiration is the first event. The second event is what happens whenever you have that intrathoracic pressure change. And the third thing is what happens when you get an angry epiglottis. So the first thing that happens is you take a deep breath in, so inspiration. When you try to take that deep breath in, you change the pressure. So then you cause a negative pressure change. And that's going to help to pull air into the lungs, but through the larynx. When that happens, the air, as it moves past this area, bumps the epiglottis. And it tries to push the epiglottis down. And that blocks off the laryngeal inlet. So basically what happens is the air ball valves is what I want you to remember. It ball valves the laryngeal inlet. So now, as air is trying to rush its way in when you take a deep breath, this is blocking it, and it's impeding the airflow. And this is kind of it's almost as if the patient is almost like asphyxiation. And that is terrifying because that can happen as this gets potentially worse. So there is a massive reduction in airflow. And that's what really gets scary with this condition. All right, so epiglottitis, what do I want you to take away from this? First thing, it's often due to Haemophilus influenza type B, but that was pre-vaccine. As vaccines started to come about, what was the primary pathogen? Staph aureus strep species. Again, we can cover all of those with ceftriaxone. You get an infection by those bacteria. They cause cellulitis. They cause enlargement of the epiglottis. What's the primary tissue makeup of the epiglottis? Elastic cartilage. Why is that important? Because it's supposed to make it bendy, right? So whenever this thing gets inflamed and enlarged, the bendiness becomes worse. And now this thing can flop around. If that happens, it can ball valve off that actual laryngeal inlet with just taking a breath in. That's where the most concerning features come about. But we also don't want to forget about the other possibilities here, that thing being inflamed, it's innervated by nerves. It causes pain with swallowing. That makes you not want to swallow, so you drool and you could pull up secretions. And then whenever you try to speak, it causes this type of change in your speech where it sounds more muffled. One last thing, and I think this is kind of interesting, is there is an important kind of there's a high yield takeaway and something that on the exams they're going to try and present to you. And I think the understanding of why they do this is kind of cool. So whenever these patients have epiglottitis, think about this thing. This thing is naturally bendy because of the elastic cartilage. When you make it inflamed, you make it angry. What is it going to do? It's going to cause that thing to start to do what? Maybe kind of flop a little bit naturally. And whenever you take a deep breath in, it's going to push the air, is going to ball valve it over the laryngeal inlet. What if the child leans forward? So they kind of brace themselves like this. They hold their arms up, and now the laryngeal inlet could potentially be open because you're going to pull the epiglottis just even a few millimeters more anteriorly. So one really, really key thing here is a key distinction for epiglottitis is you want to look for something called the tripoding position. So you want to know something called the tripod position. And this is kind of like a survival instinct, if you will. And the whole point of the tripod position is to move epiglottis like a few millimeters. That's how much. A few millimeters anteriorly. And that theoretically can open up the laryngeal inlet just enough for more airflow to come in. And so whenever you notice this, you notice a child who has drooling, difficulty swallowing, a lot of pain in their throat, they have dysphonia, that muffled hot potato voice, and they have also this tripod positioning, that's pretty concerning. But there's one other thing. Whenever air flows across this kind of obstruction, it causes a massive kind of turbulence of airflow. And that turbulence of airflow, whenever it ball valves, produces a characteristic sound. And this sound is what we refer to as stridor, which is this really, really loud, harsh, whistling sound that as air is rushing across that narrowed laryngeal inlet, it produces that kind of high-pitched sound. And that is referred to as stridor. So there's a couple other things that are really, really critical. We will get into this in the airway obstruction, but I would add this into the mix, that whenever you have a patient with the 4 Ds, and they also have stridor, and this survival instinct type of positioning that screams epiglottitis. And this is a patient that you don't want to go messing around with and trying to fiddle around with and look in their mouth and poke things and say, oh, let me touch the thing. No, you're going to potentially put them into an actual worsened situation, further respiratory distress, maybe complete total airway obstruction, and they can asphyxiate and then go into acute respiratory arrest. So this is a really, really important one that I need you guys to have down pat. With that being said, we'll move into the one that is probably less concerning, but again, I think it at least involves just a quick discussion. That's laryngitis. Laryngitis can be infectious, all right? So if I were to talk about this being an infectious etiology, what would be the infectious etiology? Well, the infectious etiology, oftentimes more than not, is usually some type of virus. It's rare. I mean, almost never is it usually bacterial or any other kind of like origin. It's usually viral. And probably the ones that you want to think about most often is something like the rhinovirus. And this is probably more often than not associated with like generally like unspecified upper respiratory tract infection. So they probably have a person who also has not just infection of their larynx, they probably have some of their pharynx, maybe the sinuses. So they may have nasal congestion, they may have nasal discharge, they may on top of that have a sore throat. On top of that, they may even have symptoms of laryngitis, which we'll talk about, all right? Now that's infectious. It can also be non-infectious. And oftentimes we think about this. That's why I don't want you to always associate laryngitis with infectious. It can be non-infectious. If it's infectious, it's almost always viral, rhinovirus. If it's non-infectious, this could be other things. For example, again, we're talking about infectious diseases here, so I don't want to go too crazy, but I do want you to understand it's not just an infectious etiology in general. If we talk about this, we see this a lot with GERD. So GERD, whenever you have reflux, that reflux, if you have movement of some kind of like a little bit of gastric acid out of the esophagus and into the laryngeal inlet, it can irritate those vocal cords, and that can cause this. Another one is just straining. So people who are going to a concert and they're screaming their lungs out because they saw Ed Sheeran, right? And so that's a concept here, is that we can see this. It's more due to straining of the vocal cords. You're having them move so much that they get inflamed, or you have something that causes a little bit of chemical injury, such as acid reflux. All right. So this is the big thing I want you to think about. Let's say that a patient develops inflammation of their true vocal cords. And if it's infectious in etiology, it's usually a rhinovirus. And then because of that, they're also associated with, so with this, with the rhinovirus, you'll look for a person who has symptoms of an unspecified upper respiratory tract infection. So usually they'll have an upper respiratory tract infection. All right. First thing is you get a viral infection. So you get mucosal injury. That mucosal injury, which is what? Again, let's look at our structure here. If we had, you'd have the hyoid bone, thyroid cartilage, cricoid cartilage. This right here is the vestibular folds, laryngeal ventricles. What are these called? The true vocal cords, right? The true vocal cords. So really, these are the things that are getting hit. And what's causing this injury? Well, if it's infectious, it's the rhinovirus. If it's non-infectious, it's some type of chemical injury such as GERD, or these things vibrating like a son of a gun, and someone who is screaming at the top of their lungs. So you have mucosal injury. When that mucosal injury occurs, these things start to get filled up with fluid. And they start to get heavy and edematous. So now I got these vocal cords that are getting all kinds of thick. So I have mucosal swelling and a lot of edema. So I start getting what's called mucosal edema of the vocal cords. When that happens, when we actually think about vocal cords, it's actually kind of interesting how these things are structured. If we take a look here, I'm cutting through, and so let's say I take this piece here and I look at the interior. What's the inner juicy material? The primary component here is muscle. So most of the gooey center here is a muscle. It's called the thyroid arytenoid muscle. So the thyroid arytenoids. The other component here is ligaments. So we're going to have ligaments right here, which will represent in blue. So here's going to be the ligaments. So we have the muscle, then we have the ligaments, and all of that white space is called the mucosa. So we have three different components of the vocal cords, right? So the first one in red is going to be so we'll have 1 is the muscle, 2 is the ligaments, and 3 is going to be the mucosa. So again, I'll actually label these. Here is 1, here is 2, and here is 3. So again, what are these? First one is the muscle. I don't expect you guys to memorize that exact one, but it is the muscle. It's the thyroid arytenoid. 2 is you're going to have the ligaments. And 3 is going to be the mucosa. Technically we call it like Ranke's space, but I'm not going to ask you guys to remember that. Whenever we get inflammation, it's really this mucosa that gets bogged down. It gets filled up with fluid. When that starts to happen, and you get mucosal edema, what happens is these things are supposed to vibrate. Whenever air rushes against them, they're supposed to vibrate and produce different types of frequencies and sound that allows for us to have changes in our pitch, right? And so because of that, this person is going to have a change in their vibration. So we'll just say that they have a vibration failure. So what happens is, as air rushes across those vocal folds, They don't vibrate properly. And because of that, the primary clinical symptoms that these patients will present with is as air rushes from your lungs and they go up through and they undergo the vibration here at the true vocal cords, this should produce a sound, it'll undergo resonance, and that sound should be nice and clear. But if a person has laryngitis, their interruption is right here where they're supposed to vibrate. And so because of that, they don't produce that nice clear high pitch. The vibration frequency comes down. So they have a reduction, we'll say, they have a reduction in their frequency of the vibrations. And because of that reduction in the frequency, the pitch changes, and this causes the patient to present with what types of symptoms? Primarily, it's going to be hoarseness of the voice. Sometimes, in worst case scenario, they can also have aphonia, which is almost like they have no voice. So hoarseness, right? Hoarseness is one potential symptom, or aphonia, which is they literally lose their voice. This is what I would want you to think about here. All right, but here's one last thing. Laryngitis can happen on its own due to GERD, yelling, and it can be due to viruses. But oftentimes, the big thing I want you to remember here is I think it's really, really important to remember that this is often associated with an upper respiratory tract infection. So it's going to be associated, especially if it's viral. Viruses don't just attack one tissue. They oftentimes, in this case, they attack multiple different areas of the upper respiratory tract. So associated with upper respiratory tract infection. So because of that, you're going to have involvement of what kinds of areas? You can have involvement of the nasal cavity, the sinuses, the pharynx, and the larynx. And so basically what you want to watch out for is, we call this an unspecified, which if you guys want to know a little bit more about that, go watch our lecture on upper respiratory tract infections, but it's more of an unspecified. It's not localized, all right? It's not localized. And so what I mean is it's not often that these patients only get just involvement of what? Just the larynx. So they could have other symptoms such as nasal congestion, runny nose, they may have a sore throat, and they can have hoarseness of the voice. If you just have hoarseness, great. But the key thing about this is if a person only has hoarseness or aphonia, you need to make sure that they don't have some type of ongoing vocal cord paralysis. And so generally we keep a very, very close eye on this. And if it continues and continues, especially greater than 3 weeks, we would need to go and actually take a look at those vocal cords and do some types of laryngoscopy to make sure that they don't have something else going on. All right. Anyway, that covers laryngitis. Let's move into the last one here, which is Laryngotracheobronchitis. All right, so Laryngotracheobronchitis, also referred to as Croup. This is another type of infectious etiology. So we talked about Epiglottitis, we talked about laryngitis, and now we're talking about Laryngotracheobronchitis. Again, we know it is inflammation of the infraglottic mucosa or the subglottic mucosa. It's the same kind of concept here. But the etiology here is usually some type of virus. And that virus is more often than not what's called the para-influenza virus. And there is 2 different types. We'd say that probably type 1 is going to be the most common. So again, when we talk about infectious etiology, this is most often a viral infection. Now the reason why I think this is important is because when you think about laryngitis, that's a viral infection often. So do you do anything about it? No, it's oftentimes just supportive care. Hey, rest, stay hydrated. If you have any pain, treat the pain. But generally, it'll go away on its own because it's a viral infection. Epiglottitis is an actual bacterial infection. This thing will not get better if you don't treat it with the appropriate antibiotics. When we talk about Laryngotracheobronchitis, it's a viral infection. And so because of that, we're not giving them any kind of antivirals, we're not giving them antibiotics. We treat the symptoms, and the symptoms tends to be the primary problem that we see in Laryngotracheobronchitis. So this virus, what happens is, again, you guys remember the particular area? So again, just remind yourselves, this is actually going to be the vestibular folds. This is going to be the laryngeal ventricle. This is your true vocal cords. This space is called the glottis. What is this called? The infraglottic or the subglottic area. Now the mucosa is the primary tissue, the pseudostratified ciliated columnar epithelial tissue that is going to get injured. So you're going to get some type of mucosal injury. This is going to cause the death of the mucosal cells. You know what else happens is the pseudostratified ciliated columnar, epithelial tissue, it's supposed to actually have the cilia to beat mucus, right? And so you can cause what's called ciliostasis, which you actually inhibit the ability of the cilia to be able to beat mucus. And that creates a potential problem, which we'll talk about a little bit later. But we get mucosal injury. And again, where is the mucosal injury primarily occurring? If I said it was above the glottis, that was epiglottitis. If I said it was involving the true vocal cords of the glottic level, it was laryngitis. If I say it's below the glottis, then we're talking about the subglottic tissue. This is going to be the subglottic area. So we're going to get mucosal injury of the subglottic area, the subglottic cavity. What happens is that whenever you cause this destruction of the tissue, you create an inflammatory reaction, right? Immune system cells will come to the area because your tissue that's injured is going to release certain types of damage-associated molecular proteins. It's going to pull your immune system in. It's going to cause vasodilation, capillary leakage. And what's going to happen here is you're going to cause a lot of fluid to accumulate in that submucosal space. All right, and again, what's the primary reason? Well, if you guys remember, it's going to be because you're taking these vessels and you're making them dilated and you're going to make them super leaky, right? Because that's what happens. Those damage-associated molecular peptides and different types of cytokines, they come to the area and you want to bring immune system cells into the area and you're going to make it dilate and you're going to make it super leaky. And that's what contributes to a lot of this submucosal edema. Is you're going to have lots of vasodilation and capillary leakage, right? And so now look at all of this swelling. You see this massive amount of swelling here? The problem with this is you have the cricoid cartilage here, and you even have the annular, the rings of the tracheal rings. These basically create a fixed space. So in other words, whenever you have injury, you would like to swell outwards potentially so that you don't narrow the lumen of the larynx. But in this case, the tracheal rings and the cricoid cartilage limit outward expansion. And so where does the expansion actually occur? Inward. And that is the problem, is that we create this inward kind of narrowing of the area. And so again, what's the problem with this? As you get a lot of what's called subglottic edema. Because you can't expand outwards because of the cartilage. It's a fixed stenosis now, and it swells inward. That really creates a problematic issue. I'm not trying to go into physics, my friends, but I want you guys to understand something. Whenever air is supposed to flow through this space, naturally, if you kind of narrow the space, you change the way that the actual air flows. And so we use something called Poiseuille's law. And really all I want you guys to take away from this is that the R is looking at resistance to airflow. And the lowercase r is looking at radius. And a patient who gets croup, what really happens? In croup, what you do is you actually decrease the radius, which is the little r. So in croup, you cause subglottic edema, which narrows the radius. That's really the primary thing that we see here. So it decreases the radius of the subglottic cavity. When you decrease the radius, what happens now? Look at the relationship between the radius and resistance to airflow. It's inversely proportional, and it's to the fourth power. So if this decreases, this is going to massively, massively increase. And so what happens is this patient ends up with a massive increase in resistance to airflow. And here is the thing. If it's just a little bit, just a little decrease in the radius, you can cause a massive resistance to airflow. There's actually a note out there that really, it's kind of interesting, kind of like a little factoid, if you will. And I think it kind of just pays homage to how important this is. If you decrease the radius of the subglottic area of the larynx by 1 millimeter, it can increase the resistance to airflow by greater than 50%. That's significant. So 1 millimeter decrease, or we'll just say reduction in radius, will lead to a greater than 50 times increase in resistance. So again, if you have a 1 millimeter reduction in the radius, this is going to cause a 50 times increase in the resistance to airflow. I think that just pays kind of like an overall homage to how significant this can actually be. And because children, they don't tolerate this very well, it leads to a lot of different symptoms. And usually the symptoms that they develop because of this narrowed airway is at night. Because naturally that kind of just, you actually have a natural kind of decrease in the diameter and the radius of the larynx at nighttime. All right. When I have the reduction in the radius of the actual subglottic larynx, what are the symptoms? Well, one is it's going to cause a barking cough. We kind of define it as like a barking cough. Some may even define it as a seal-like. All right, so a seal-like cough. The concept behind this is if I take this area here and I narrow it, right? Whenever air is supposed to flow, whenever you cough, basically it's a kind of a very sharp expiration, a burst of air. Here's this narrowing. Whenever air is supposed to run out of the lungs, it's supposed to run through here and it's supposed to not have as much resistance. But if it does, it creates obviously this kind of turbulence of airflow. And that turbulence will produce this type of like sound that we hear, which is the barking cough. So really what's happening in here is as it's kind of doing this, it's creating this turbulence of airflow. And that's what gives that barking cough. So basically it causes a increased turbulence of airflow. So increased turbulence of airflow because of all that resistance. And that is what produces that barking seal-like cough. Now the other thing here is, this is usually during, whenever you cough, it's kind of like a very quick blast or forced expiration of air. Whenever you try to take a deep breath in, just like in a patient who has epiglottitis, they had a ball valve effect, right? Where the epiglottis was big and beefy. Whenever you take a deep breath in, you have a negative inspiration, a negative pressure change, and that causes, again, the air to flow into the actual lungs. But whenever it does that, it moves the epiglottis just a little bit more posteriorly and inferiorly, blocking off the laryngeal inlet, right? And as they start to do that, very little air can get into the larynx and it creates that turbulence there called stridor. It's the same concept here, that whenever a person tries to take a deep breath in, they want air to flow here, they want air to flow here, and as they start to do that, it kind of flows here and you want it to come down into the lungs. But as it does, it hits all of this kind of like narrowed area and creates some turbulence of airflow, just as we talked about it in epiglottitis. And so the primary symptom here is going to be some type of stridor. All right, and that's again due to that turbulence of airflow. Here's the thing, this can happen during inspiration and it can also happen during expiration. And so we technically may define this as a biphasic. So sometimes we actually call this a biphasic, which means it can happen during inspiration and expiration. So again, what do I want you guys to take out of all of this? In a patient who has Laryngotracheobronchitis, it's primarily viral. The viral infection causes mucosal injury of the subglottic mucosa. That thing gets inflamed. As it starts to fill up with fluid, you can't expand the actual cricoid and the trachea outwards. So what happens? It swells inward. As you swell inward, the radius starts to decrease. As the radius decreases, Poiseuille's law says that the resistance increases significantly. So now turbulence of airflow is going to be much more resistance. Imagine having to breathe through this big cavity versus breathing through a straw. That's what happens. And because of that, guess how much work of breathing it's going to require? So much more. And that's the big thing to think about with this, is that 1 millimeter reduction in radius, increasing the 50-time increase in the resistance, all that really does is, and that's what makes this thing so terrible, is it increases the work of breathing. Because you now have to work so much harder. You have to kind of take such a more effort and inspiration to try to pull the air through that narrowed subglottic area. And so that's one of the key things here, is that you notice that these patients tend to have more of a work of breathing. The more severe it gets, the more the work of breathing tends to increase. And eventually, whenever a child is breathing super, super fast and heavy and working super hard, just like any muscle, they get fatigued. And eventually it can lead to them kind of tuckering out, they get fatigued and they start to go into imminent respiratory failure because they stop taking in enough deep breaths. That's one of the concerning things about this. So Laryngotracheobronchitis, viral infection, causes subglottic edema, that reduces the radius, that increases resistance to airflow. Having to breathe through a small little straw causes you to have to work really hard. It makes the sound of breathing really, really high pitched and whistling. And whenever you try to cough, the air as it blasts through that narrowed opening is going to cause that kind of barking seal-like cough that is characteristic of this condition. Now that we've talked about all of these laryngeal infections, what I want to do is I want to talk about, we can see a patient coming in with stridor between both of these, right? That's really, really important. What you notice here is that this patient coughs. Epiglottitis doesn't really cough. You want to know why? Because they're terrified to cough. Because if they cough and air comes and hits that beefy, angry epiglottis, what's going to happen? It's going to hurt. So subconsciously they know, oh, if I cough, I'm in big trouble. So that's kind of an interesting thing where both of those can have stridor. This one coughs, this one doesn't cough. This one probably is much more sick, this one not as sick. They don't look as toxic. Usually this one has a pretty high fever. This one doesn't really have that high of a fever. Laryngitis is just a dude who's coming in who's got some hoarseness of the voice, or maybe their voice is lost. So what I want to now talk about is, how would a patient who has something like laryngotracheobronchitis become really severe? How do I differentiate airway obstruction presentation between the two? And how do I talk about the feared high rate of mortality which can come with something called post-obstructive pulmonary edema? Let's dig into it. All right, so let's talk about the complications of laryngeal infections. And really what it comes down to is a patient does have a potential risk of something called bacterial tracheitis, especially when a person gets viral laryngotracheobronchitis, which is Croup. It basically sets the stage for a potential bacterial kind of super infection, if you will. And the bacteria that we most often see this associated with is called Staphylococcus aureus. Now, Staphylococcus aureus, the one that we actually really don't like, is the methicillin-resistant Staphylococcus aureus. And that's something that we can see with this type of infection, right? So the viral infection basically primes. Viral infections, what we know is it always kind of sets the stage because, these viral infections, they damage the tissue, right? So they kind of expose the underlying basement membrane and connective tissue. On top of that, you also kind of exhaust your immune system, right? And so when you exhaust your immune system, it just creates a perfect environment for MRSA, Staphylococcus aureus, to come in there and really cause some pretty nasty damage. So first thing that you have to remember is, in order for this to really occur in this kind of setting, is you needed a patient to have some type of viral infection that preceded this. And usually this is Croup, right? And so what happened, if you guys remember, in a viral infection like Croup, what did that present with? Well, it caused that subglottic edema. That was the key thing there, is it caused the subglottic mucosal edema. So you got subglottic mucosal edema. Now, if you guys remember, I told you back in that scenario there that whenever a person gets some kind of inflammation in here, really what was happening is that you were kind of causing the vessels to undergo vasodilation, you were making them super leaky, and as a result, you were getting a lot of fluid leaking into that submucosal space. And whenever that happens, we told you that really one of the problems here is that it can't expand outwards, so it expands inwards, right? That was pretty common that we talked about that. Here's the thing, if we actually zoom in on this tissue and understand how the virus actually does this, we actually can kind of zoom in on it right here. So here's this black line, all I'm doing is I'm zooming in on that particular area. So if you can imagine, what I'm doing here is I'm taking this piece of tissue here, and I'm just kind of zooming in on it is all I'm doing. And looking at this on the cellular level. What happens is that the virus causes injury to these cells. So it causes injury to the pseudo-stratified ciliated columnar epithelial cells. Now, these epithelial cells have something called cilia, and the cilia are naturally supposed to beat mucus that's produced by different types of goblet cells and beat them upwards, right? So that we can either swallow that kind of mucus or spit it out. Well, what happens is whenever you get a viral infection, it does two things. One is it damages the cells, so it causes cell damage, but also it causes the cilia to stop functioning. So it causes cell damage, right? And then also causes what we refer to as ciliostasis. Essentially what it does is it paralyzes the cilia. And what the cilia are supposed to do, as we said, is it's supposed to beat the mucus And actually, we would want it in this case, we want to beat it upwards. So we're going to have it go this way. You'd want it to beat the mucus upwards so that you can spit it out or swallow, right? But this is going to be impaired. So you're getting cilia stasis and you're also getting cell damage. What this does is it creates the perfect storm. The perfect storm which we need for bacteria to get in here and to start kind of really causing some damage. So here we've already set the stage. We got some inflammatory kind of exudate all in this area. Here's all the inflammatory exudate. We already have this mucociliary escalator being damaged. What's the problem with damaging the mucociliary escalator? When I cause ciliostasis, this causes mucus to build up. If I can't beat the mucus upwards, it's going to stay in that area. And what ends up happening is you get a buildup, potentially, in mucus. Now, I'm going to have the edema because I'm causing tissue damage, bringing in blood flow, making the capillaries leaky. But on top of that, I'm going to start getting a little bit of mucus that's going to build up here. I'm going to get a little bit of mucus build up. Now, what happens here is I've damaged the tissue. I've created a perfect environment for the Staphylococcus aureus to come in here now. So now the Staphylococcus aureus is going to get into this area here. And what it's going to do is, I need my purple marker here, is it's going to get into this area. It's going to get stuck into the mucus. It's going to get stuck into this mucus. And then it's going to start releasing different types of toxins. And that's going to start damaging the mucosa. And you're going to start getting a lot of necrotic debris. You're going to start killing a lot of this actual mucosal tissue. Significant extensive damage. So here, I'll represent this now. As you're going to get all of this kind of like debris, you're going to get all this damaged tissue here, maybe some damaged tissue here, getting some necrosis. Getting all this necrotic tissue now because of the bacteria. On top of that, your immune system, your neutrophils are going to want to come to the area and fight off the bacteria. When neutrophils and bacteria and dead types of tissue combine together, what do you get? You get more of like a pus material. So now what happens is I have this mucus and I'm going to start causing it to get more pus-like. It's going to get more exudative. And then it's going to start really getting thick into this subglottic area. And what ends up happening is you create something called a pseudomembrane. And that's what's really important here, is that we create something called a pseudomembrane. It's kind of like in diphtheria. In diphtheria, we had the bacteria release exotoxin, killed the actual cells. Then what happens is it pulled neutrophils into the area. The neutrophils with the dead cells and the bacteria all mix together, and then fibrin comes in and forms that big mesh over top of it. It's similar to that, but the pseudomembrane is causing two potential problems. One is, and again, really what is it? It's basically, it's mucus, dead cells, neutrophils, and bacteria, all mixed up into one big soup. All of it's just mixed up into one big soup. Here's why this is kind of super dangerous. When we get this kind of scenario, we have a couple different issues. One is that if this kind of membrane breaks off, it can kind of float down further. If it gets super thick enough that it actually obstructs this entire airway, you can get kind of a complete mucus plug. So let's talk about what that could look like. Well, one of the first things here is if a patient gets this big, let's just say, area here. So what do they have? They have kind of a narrowing. They're going to have a narrowing of their larynx and their trachea. Same thing over here. They would have an obstruction of the larynx and the trachea. It's going to be filled with a lot of fluid. You're going to then cause bacteria to go in there. They're going to start causing a lot of damage, necrosis. Neutrophils are going to get migrated to the area. And they're going to get all of this kind of necrotic debris here, filled with neutrophils, dead cells, a lot of mucus. This is going to activate cough receptors. You know, you have different types of like cough receptors. What color should I pick for this one? Let's do it like pink. You have all these different types of receptors here, which are supposed to pick up irritants and trigger a cough reflex. And so that's what will happen here is you're going to trigger a pretty significant cough reflex from all of that mucus and irritation. So the patient will get a cough reflex, just in the same way that a person who had croup will have a cough reflex. The difference is when you cough, in croup, it's more of a dry, barking cough. In this scenario, if you force enough air, pretty good amounts of it, up through the lungs, you can dislodge some of that mucopurulent debris. And if I break a piece of that mucopurulent debris out, what am I going to get? I'm going to get more of a productive cough. And that is really one of the key differences here, is when you look at croup, they have more of that dry, barking, seal-like cough. And a person who has something like bacterial tracheitis, they have a very productive, and sometimes we would even say a purulent cough. When you look at their sputum, it's got a lot of that mucus and dead cellular debris and that kind of like overall inflammatory infiltrate. That's really one big difference here. The other thing is that whenever you have bacteria like this that cause that much damage, what we know is that these bacteria, they trigger a lot of cytokine reactions, right? So they release things, right? So a lot of what happens is whenever the bacteria cause tissue damage, the tissue damage activates immune system cells like neutrophils, macrophages. They trigger a lot of cytokines to bring in more immune system cells. And they release things like interleukin 1, interleukin 6, TNF alpha. And all that does is that goes to what area? Well, if you guys remember, we have a particular structure here called the hypothalamus. And it activates the hypothalamus. And the hypothalamus can precipitate a kind of uptick in your overall thermostat and body temperature. And so what happens here is all of these cytokines activate the hypothalamus, and that triggers the fever. And this fever is usually pretty high, and they just overall, they don't look very good. They're pretty sick looking, right? So this is one really big difference here is that croup, you can have a fever, but it's not gonna be like a super high grade fever. It usually will be a low grade. They're not gonna have a productive, purulent-like cough generally, but in someone who has a very, very productive, purulent, even foul-smelling kind of cough, in combination with a super high fever, and maybe prior to this, they had a viral prodrome like Laryngotracheobronchitis, you definitely want to be concerned about that. But here's the biggest concern. We have the productive purulent cough, right? We have the fever, right? The other thing here is that they can cause airway obstruction. So this is probably one of the most concerning features, and I'd say more than 50% of these patients end up intubated, right? So they can end up with a pretty significant airway obstruction. In some cases, they can even asphyxiate if you don't actually intubate these patients and suck that mucus plug out. So because of that inflammation and that pseudomembrane here, we got all this pus, we got all this mucus, we got all this dead cells, we got all the neutrophils, all this inflammatory exudate, and it's plugging up the airway. One thing can happen from the airway obstruction. One is you can completely just obstruct the trachea. The other thing is that some of this mucus plug can break off and it can obstruct a bronchus. So two things could happen. This thing could break off and get maybe further down by the trachea, by the carina, or it can go into a primary bronchus. So you can get this thing to break off, or it can completely obstruct airflow. So now air is trying to come in, air is trying to come in, it flows, and then all of a sudden, as it runs through here, it hits this. Airflow is going to stop. Right? Airflow is going to stop. And if it does get through, it's going to have a lot of turbulence. And so obviously things that you really get concerned about with this is that they may have things like stridor, right? So if you had a little bit of an opening maybe, if I actually kind of, let's say here, I gave them a tiny little opening. So let's say here I gave them a tiny, tiny little opening where air was able to kind of trickle through here. So here's all of this kind of mucus debris. It's all here. And maybe they have a tiny little tunnel. Maybe they have a tiny little tunnel here where air can kind of like get through. If that happens, it creates a turbulence of airflow. And that turbulence of airflow will be heard as kind of a high-pitched whistling sound. What's that called? Stridor. So one thing that we definitely want to watch out for here is the presence of stridor. Here's where we kind of try to add on a little clinical significance. If I had a patient come in who had stridor, they had a cough, Maybe they're of age. They have that potential concerning feature that they may have croup. Maybe they have a fever, maybe they don't. One of the big things that helps us to really differentiate between those who have kind of like a viral croup versus bacterial tracheitis is how they respond to particular therapies. In this scenario, bacterial tracheitis has a pseudomembrane. They don't only have subglottic edema, so they have edema there, but they have a pseudomembrane. So what ends up happening is we do something very interesting where we have this stridor and we give a person a treatment. And so what we're gonna do is we're gonna give two therapies. Let's actually make a little bit more room for this one. So we're gonna give two therapies. One is we're gonna give them something called dexamethasone. So we're gonna give them something called dexamethasone, and we're gonna give them something called racemic epi. And again, we'll get into this a little bit later. But what these are gonna do is these are supposed to reduce subglottic edema. They won't do a lot against a big plug of pus and debris and all kinds of stuff like that. But if I give dexamethasone and racemic epi to two patients, right? And what ends up happening is I see an improvement. Or I see no change. That kind of tells me something. So if I give them dexamethasone, racemic epi, and I see improvement, that tells me that this is probably most likely just subglottic edema. And that's Croup. If I see no change, this could be more. This is some kind of like foreign body. The pseudomembrane is really causing the problem here. And this would potentially make me think more about the Croup versus something like bacterial tracheitis. That is kind of what we think about here. Now, we'll talk about this a little bit later because we're going to get into x-rays. We're going to get into certain types of imaging techniques and things like that. But when you look at a person who has this type of bacterial tracheitis, they have all of this narrowing, you would look at an anterior AP neck x-ray and they would have a lot of narrowing of their larynx and even going into their trachea. And so we call that potentially like a steeple sign. The difference is that you see how all that gooey pseudomembrane can kind of like drip down and pop things off to obstruct further down the airway. You might be able to pick that up. We call it like a shaggy tracheal borders, and we'll get into that. But really when we talk about this patient who comes in, they are going to look significantly sick. They're going to have signs of stridor. On top of that obstruction of the airway, not only will they have stridor, but they'll have other features that really concern us, probably even more, which is they're going to have significant work of breathing. So they'll have increased work of breathing, potentially hypoxia, and that's really what we get scared about. We'll talk about that in the airway obstruction, but these patients are going to have a significant amount of work of breathing, and potentially they may have hypoxia, and sometimes they can asphyxiate if you don't get that obstruction out. This patient will look super sick. You probably don't have time to get x-rays. So because of that, oftentimes we diagnose this upon generally, we'll intubate the patient, get their airway stabilized. Sometimes we'll suction and see if we can improve. Sometimes you may even have to do a bronchoscopy for these patients to truly find that pseudomembrane. But again, we'll get into that. But that's bacterial tracheitis. Bacterial tracheitis is really a bacterial superinfection that was really kind of built upon the foundation of a croup infection. So they ended up having a viral infection. That viral infection caused them to have a perfect storm, the perfect medium for MRSA to grow. When that MRSA grew, it caused a pseudomembrane, it caused a mucus plug within the airway, obstructed the airflow, caused them to have more of a productive cough due to that kind of purulent mucus type of tissue that was there. And on top of that, they also will have stridor, they'll have signs of respiratory distress, but generally when we think about croup versus bacterial tracheitis, one is primarily subglottic edema. One is subglottic edema and a pseudomembrane. Which one's gonna improve with steroids and racemic epi, which helps to reduce swelling? The croup. You won't really see that much improvement, if any, at all with bacterial tracheitis. Airway obstruction is really the key concern with these types of infections. When you have an upper airway obstruction, those are pretty concerning. Let's think about the reasons why. The three big conditions I've talked about today. One is epiglottitis. So if a patient has something called epiglottitis, that is due to inflammation of the epiglottis that is obstructing the airway. How does it do it again? It does it via that ball valve effect, which we talked about. right? Which is whenever you take a breath in, you create a negative pressure. That negative pressure causes airflow to come through here. And whenever that airflow does that, it pushes the epiglottis just down a little bit to narrow the laryngeal inlet and reduce airflow, all right? So all of this is air is trying to come through, air is trying to come through, but what ends up happening is we end up having some kind of blockage in some way, shape, or form to get the air down. And it's where is the obstruction, all right? Epiglottitis is right here. You're obstructing it at the laryngeal inlet. The second one we talked about is croup. Now, croup is definitely something that can cause an airway obstruction, but usually we see this more in the severe cases. How does it cause it? It leads to that fixed stenosis. And this is via that subglottic edema. And that's narrowing the airway. Remember, Poiseuille's law, we cause a drop in the radius, which increases the resistance to airflow. Even a millimeter reduction can cause a greater than 50% increase in resistance to airflow. That's gonna make the patient have to work harder to breathe. And the third one is gonna be right here, all right? So we have croup right here, and the third one is bacterial tracheitis. These are the three ones that can cause potential airway obstructive symptoms. If you had to remember, probably the most concerning one though, and the one that you'll see on the exam, it's going to be epiglottitis. But bacterial tracheitis, how does it produce an airway obstruction? It's not just subglottic edema, it's the pseudomembrane. We keep trying to build off of this concept every single time. So whenever we build a concept, all I'm going to do is just say it again and say it again, so that repetition-based learning comes into play. So again, this is going to be the pseudomembrane. Right? And you can think about it as that big mucus and pus plug that's accumulating there. Now, all of these things are blocking airflow. Why is that a problem? Let's take a second here. Let's say that we get down to this alveoli. And by the time air gets down to this alveoli, what's really happening? So we zoom in here. As we zoom in, you need to know that at the alveoli is where gas exchange is occurring. So generally what happens is oxygen should be coming in, and CO2 should be going out. We know this. This is basic physiology, right? So oxygen should be coming in to this alveoli, and if you have the proper scenario, you should have gas exchange. CO2 should be going out, and if everything is appropriate, it should be going this way. What's happening is that you're having a reduced ventilation. So these patients have something called hypoventilation. So really their primary issue here is something called hypoventilation, and that's due to the airway obstruction. That means very little gas is coming in and very little gas is going out. So what's end up really occurring here is that I'm blocking O2 from getting in and CO2 from getting out. What's the end result here? The end result is I end up with a patient potentially with what's called you end up with a mixed. So we end up with what's called a type 1, if you guys remember this from our pulmonary lectures, and type 2 acute respiratory failure. And so what we see is they have a really low oxygen and they have a high CO2. And what happens with this is, what do we call this whenever you have low oxygen? What is this called? Low oxygen within the blood and high CO2 within the blood. This is called hypoxemia, and this is called hypercapnia. So that's what I want you to remember, is that they have a low oxygen and potentially a high CO2. And this here is called hypoxemia. That's usually your type 1 respiratory failure. And then hypercapnia, which is usually, if it's on its own, is your type 2 respiratory failure. This has a mixture of the two. Now, when you talk about hypoventilation conditions, they oftentimes present more likely in the beginning with the hypercapnia, as not as severe of the problem with the oxygen. As conditions continue to go on and it gets more and more severe, hypoxemia starts to become a little bit more prevalent. But what would this patient look like? If any of these patients came to you, what would be the first concerning thing that you would look for with the airway obstruction? Well, it would be potentially signs of hypoxemia and hypercapnia, right? So how does hypoxemia, that's probably one of those that if you see this, you should definitely be concerned. What would that potentially look like? Well, it could look a couple different ways. One is if you ended up getting a pulse ox on the patient, they would have a decreased SpO2. And that's probably the biggest thing, is that you would look on their pulse ox and you would notice that their SpO2 is actually going to be relatively low. Or if you got an ABG, they may have a decreased PaO2 on ABG. And so these are the general things that you would end up finding on this patient, right? So that's one thing. The other component here is whenever a person has hypoxemia, you have a natural response. Whenever you have hypoxemia and hypercapnia, you have a compensatory response in that scenario. What is it? To breathe faster, to breathe deeper, to work harder to breathe. And so because of that, all of these patients usually have a significant work of breathing. And that's probably one of the signs that you see, especially in things like croup. You can see it potentially in epiglottitis, and you can see it in bacterial tracheitis. But work of breathing is probably a pretty concerning sign. It tells you that they're definitely doing the best that they can to try to compensate for the airway obstruction, the hypoventilation, the hypoxia, and the hypercapnia. And what would this look like? Well, work of breathing could look a couple different ways. One is they could have, well, they could be breathing fast and deep. So they could have tachypnea, right? So they could have tachypnea. The other thing that they could have is they could have nasal flaring. They could have intercostal retractions. All of these are concerning signs, and sometimes it's even paradoxical breathing. So all of these would be signs that the patient is working really, really hard to breathe. And that's to compensate for the airway obstruction that they're exhibiting. The next thing that we also watch out for is stridor. So stridor is really one of the key features that you'll kind of notice between these two. And the stridor is due to the airway obstruction. As air is coming in through this kind of obstruction at the epiglottis, the obstruction at the subglottic edema, or that pseudomembrane, it's hitting that and it's creating this kind of high-pitched whistling sound. That's the key difference here. And again, I told you that there was one other thing to add on to that. In epiglottitis, with that stridor, what's the instinctual change that they have? So think about, if you see an epiglottitis, they'll definitely have this one, but there's one other thing to add. Epiglottitis is going to cause a tripod positioning. And that is their way of, that's survival instinct, if you will, to help them to kind of just move just a little bit, that epiglottis a little bit more anteriorly and superiorly so that I can get air into the larynx. So that's kind of the big things here. Now, this is the worst case scenario. Sometimes, you know how a person would actually present like a child? They may not want to do anything. They're scared. And so maybe they're super quiet. Maybe they're trying to stand really, really still. Maybe they're leaning forward. They just don't want to do anything excessive because of the problems that it can cause. And so sometimes it may even be in like a very young child. It may be that there's not a lot of crying. They may be really, really quiet. They kind of don't want to move around a lot. Those are other potential features, but this would be the worst case scenario. So if you see things like this is when you start to get a little bit scared, is when a patient presents with hypoxia. Another thing here is not only can hypoxia cause SpO2 changes, if it gets severe enough, and this is when I'd say this is probably the most ominous, is when you start to notice maybe bluish discoloration. So I would even watch out for evidence of potentially cyanosis. This is when you know you got a patient who's really, really sick and you need to intervene right away. That's why the important thing to take away from this is if I have a patient who has a significant airway obstruction and I can see it by any of these potential signs, the thing that comes with the most important decision making that you have to implement is stabilize the airway. So before you do anything, before you start getting tests, before you get blood work, before you kind of look in their mouth, do anything like that, you need to stabilize the airway. The concept behind this is that if you don't do this and you let the obstruction continually get worse and worse, it may be too late. And then you have to go to things like doing a cricothyroidotomy. You may have to kind of have this patient completely undergo asphyxiation. They may go into acute respiratory arrest. They may go into potentially into a deadly cardiac rhythm because of the significant hypoxia, and they code on you. So it's really, really important to stabilize the airway. That is the most important thing before getting an ABG, an X-ray, a chest X-ray, any of these things. Stabilize the airway first. All right? Now, the last one is kind of interesting. I've only seen this condition once, And it was unfortunate, it had nothing to do with epiglottitis. It had nothing to do with bacterial tracheitis or even severe croup. And I'd say when we talk about severe croup causing things like airway obstruction, it usually has to be pretty severe. Their Wesley score has to be 3 or greater for me to start being concerned about things like that. But I actually had a patient who actually got strangled by a boa constrictor around their neck and ended up having kind of a similar kind of like physiology where you basically obstruct the airway. Almost no air is getting in. And if almost no air is getting into the lungs, what ends up happening is you create these pressure changes in the thorax that essentially pulls fluid out of your pulmonary capillaries and into the interstitial space in the alveoli, and it fills up with all this fluid. And they end up pretty sick. So let's talk about this. What are the reasons why that would happen? It's actually kind of interesting. Well, first thing is you need an airway obstruction. And you need a severe. I'm talking severe, and I would say almost total airway obstruction. And so that's why we can see this in situations like bacterial tracheitis. You can see this in situations like epiglottitis. I'd say it's kind of rare for you to ever see this in something like croup, but I put it there just in case. But again, I would say the real scary one is probably epiglottitis and potentially like a severe bacterial tracheitis. What happens here is when you have that severe total airway obstruction, air is supposed to flow here, air is supposed to flow here, and they want to go this way. But what happens is you are pretty much, let's just use epiglottitis as the perfect storm example here. You are blocking zero airflow. That means almost no airflow is getting into the lungs. When you have this obstruction, what happens is it causes the patient to go into panic mode. When they go into panic mode, the natural response is to take a deep breath. So when you have this massive obstruction, they go into panic mode and they take a deep breath in. So that's the first thing, is it triggers this deep inspiration. Now, when you trigger this deep inspiration, what's going to happen? Well, you have muscles that are supposed to be controlled by your nervous system to contract. So which muscles will contract? Well, one is you're going to need your intercostal muscles to contract and help to pull the ribs upwards and outward. That's one thing. So the ribs should go upwards and outwards by the intercostal muscles, right? Then your diaphragm should start to go down to increase all of your thoracic cavity volume. So those are the two things that should happen here. One is you should cause the intercostal muscles to contract and go like the bucket handle movement to open up the thoracic cavity, and the diaphragm to go down. All of this increases the intrathoracic cavity volume. When you increase intrathoracic cavity volume, what happens is, you see here, this pink layer here is called the parietal pleura. It's connected to your chest wall. When you want to take a deep breath in, you pull on the parietal pleura outwards. And what that does is it creates this space here, which is the pleural space. The pressure in there drops, all right? So what it's going to do is it's going to cause a drop. It causes a negative intra-pleura pressure. Now, this is normal. You should, in a normal human being, have a normal drop in your intrapleural pressure. That should happen. Why? Because if I pull on the pleura, the parietal pleura, then what do? I create a pull on the visceral pleura, which pulls the lung open so that air can flow in. But this time, that negative intrapleural pressure in this person's experience is massive. I'm not talking it drops down by like -5. I'm talking this thing drops down by -50, -100 centimeters of water. That's absolutely insane. Because of that, if I pull on the parietal pleura, the pressure in the pleural cavity drops significantly. That's going to want to yank and pull on the visceral pleura, and it's going to pull and pull and pull. But no air is coming in because you completely obstructed it. Because of that, it causes some changes in blood flow. All right. So then what happens is very interesting here. You get a couple different things. The negative intrapleural pressure causes changes in pulmonary capillary pressure dynamics. So we'll write it like that. That's a lot of words there. But it causes changes in the pulmonary, we're going to call it the microcirculation. The microcirculation. And we'll zoom in on it. So it's kind of interesting. You get an obstruction, you take a crazy deep breath in. That causes a massive, and I'm going to put some red arrows here, negative intrapleural pressure. I'm not talking a small one, I'm talking a massive one. How bad? Sometimes they drop down to -50 to sometimes 100 centimeters of Water. That's crazy. That's going to try and pull on the visceral pleura, but your lungs aren't going to be able to expand because you have no air coming into them. What it does is it changes that pulmonary microcirculation. Let me explain. One of the things that happens here is when you cause that negative intrapleural pressure, what you try to do is your whole intrathoracic pressure should drop. When you have a drop in your intrathoracic pressure, what should happen to your pulmonary venous return to the right heart? It naturally should improve. You should have an increase in venous return to the right heart. So that's one thing that happens is you get an increase in venous return to the right heart. So more blood is going to go back from the superior vena cava, inferior vena cava into the right heart. When that happens, that means that you're going to have more blood going through the pulmonary arteries then. Because if I have more blood coming into the right heart, that means I'm going to have a larger volume of blood going to the pulmonary arteries. So I'm going to have an increased pulmonary artery blood flow. Oh, this is interesting. So I have increased venous return to the right heart because of that massive drop in the intrathoracic pressure, particularly the intrapleural pressure. That's going to cause me to get more pulmonary artery blood flow because here's the goal. If you think about it kind of logically, if you take a deep breath in, your goal is to pull a lot of air in. If you're going to pull a lot of air in, you want enough blood going to that aerated lung, theoretically, to allow for gas exchange. But in this person's situation, I'm not bringing much air in at all. But the body in this situation doesn't know that. And so it's sending a lot of blood to the hopeful goal that it's going to go to a lung that's going to get aerated to undergo gas exchange. But it's not going to be helpful. The other thing here is, I don't want to get too crazy, but when you have this pull on that visceral pleura, it wants to pull the lung open. But because it can't pull the lung open because you're not giving it any kind of gas to open up, what happens here is it gets transmitted to the pulmonary interstitial tissue. And so what ends up happening is you get a decrease in what's called the pulmonary interstitial pressure. The pulmonary interstitial pressure. And when you have more blood flow going from the arteries, guess what happens to your pulmonary? Hydrostatic pressure. Pulmonary, did I spell this wrong? I can see him freaking out over there. Interstitial pressure. Now, when I have a drop in the pulmonary interstitial pressure and I have more blood flow going to the right heart, going to the pulmonary arteries, that means that my hydrostatic pressure in the pulmonary capillaries is going to go up. More blood flow, more force to push things out of the capillaries. So then what's happening is, as I get an increase in the pulmonary hydrostatic pressure. And again, what is the hydrostatic pressure? The hydrostatic pressure is the pressure that pushes things out of the capillaries. Now look at these two things that we have here. There's two problems that exist. These two things, let's make sense of it. I got basically no air coming into the lungs because I have a complete airway obstruction. So what's happening here is I want to get air to come down, but it's not happening. All right? That's being blocked. What happens as a result is this pressure here in this space. What is this space here? This is the space between the vessels and the alveoli. This is called your interstitial space. What's happening to the pressure there? I'm having a decrease, and we'll kind of like write this as, let's put pulmonary interstitial pressure. So for right now, let's just make that PIP. So pulmonary interstitial pressure. And then I'm having tons of blood coming into this area. And what's that going to be representative of? That means that the pressure inside of the arteries is going to be high. So let's call pulmonary hydrostatic pressure. So we'll put PHP. So we'll put PHP. I have lots of blood flow coming into this pulmonary artery. If that happens, where I have lots of blood flow coming in because of an increased venous return, this pressure here is really low, and it's negative because I was stretching and trying to pull on the interstitium, creating a little bit more space that drops the pressure down. What's going to be the net effect here? Because Naturally, what we want is the pulmonary interstitial pressure is trying to push against things coming out of the vessel. I have something that's trying to push things out of the vessel. This is going to be much higher, and I'm going to want to push this direction, and I'm going to have less resistance to me pushing things out that way. So the net result here is that fluid starts leaking out. And where does it leak? Right into the interstitium and into the alveoli. Because the pressure inside of the alveoli is low. And so what it's going to do is, instead of pulling air into the lungs, it's going to pull fluid out of your blood vessels and into the alveolar spaces. So what ends up happening is we get these alveoli get filled with fluid. And it's going to be all over the place, man. This is really the result. So what I want you guys to remember is, in a very general way, you have an obstruction, you take a deep breath in, your intrathoracic pressure drops. When your intrathoracic pressure drops, it creates changes in flow of blood. If air can't get into the alveoli, guess what you're going to do? You're going to pull fluid out of the capillary system into your alveoli. They get filled with fluid. This is now going to be called pulmonary edema. So this is called pulmonary edema. This is going to worsen gas exchange. And so the way that this patient will present will be potentially worsening respiratory failure. You're going to affect their gas exchange, dude. They can end up with severe hypoxemia, right? And they're going to present with worsening respiratory failure. That's going to cause worsening hypoxemia. That's going to cause increased work of breathing. That's going to cause them to really, really look terrible. The other thing here that's going to be really, really critical is, once you intubate the patient, you relieve the obstruction, all right? So right now you have an obstruction. If I put a tube into the airway and I get rid of the obstruction, all of that fluid that's in the lungs are going to come rushing out of the tube and into the actual suction. And so what happens is, once you intubate the patient, you notice that they have a high flood. They end up with a high flood of pink, frothy sputum. And this is really the key thing here. So they end up with this massive pulmonary edema, and we kind of call that, whenever it happens rapidly and quickly, we technically call it flash pulmonary edema, which you can see in situations like heart failure, like acute decompensated heart failure. In this case, that flash pulmonary edema is due to an airway obstruction. When you relieve the obstruction, you're going to get a flood of fluid that's going to come out that endotracheal tube, and you'll notice that. But what happens is the patient will have an airway obstruction. They'll end up having signs like stridor. Maybe they're tripoding. Maybe they're working hard to breathe. All of a sudden, you end up worsening respiratory failure. And on top of that, you get a chest x-ray, right? So maybe their initial chest x-ray looked clear. If you got a chest x-ray on this patient, what would you notice? The chest x-ray would show diffuse edema. And that would be pretty helpful. So you'd have worsening respiratory failure, and in combination to this, if I got a chest x-ray, I'd have a significantly abnormal chest x-ray that would show diffuse, potentially bilateral pulmonary edema. Put the tube in, relieve the obstruction, whew, a flood of pink frothy sputum. That's gonna scream post-obstructive pulmonary edema. All right, that was a lot of stuff. Laryngeal infections, I think, can be boiled down to, a lot of the times, thinking about the way that the patient presents, and then knowing the exact type of test that you should be instituting for this patient to figure out what is the likely condition. A lot of these are clinical diagnoses. You don't actually have to get imaging and labs and all these other things. But let's talk about that in detail in a step-by-step systematic process of how we would go about diagnosing these types of laryngeal infections. All right, my friends, let's now talk about the diagnostic approach to laryngeal infections. With laryngeal infections, there's not like this, it's not like a common symptomatology per se that's among all of them. When we talk about these, it really, as we discussed, it comes into epiglottitis, it comes into laryngotracheobronchitis, and really laryngitis. And so they can have some can have similar presentations, and some can have just very different presentations. I think the key thing is differentiating the ones that are more of a higher risk. You can't miss these, they can go south on you, versus the one that's like, usually laryngitis, that's not going to be something that I have to be immediately concerned about. And so how do we really do that? Since laryngeal infections, it's kind of the inlet into the airway. It's a very critical structure. And any kind of swelling, inflammation that occurs around the supraglottic or the subglottic areas can really narrow the passageway of air. And that can lead to stridor, that can lead to signs of respiratory distress. And that's what's really critical. And so the first thing that you have to be able to identify in these patients is the presence of stridor and or signs of respiratory distress. And so what does stridor kind of sound like? Well, let's take a second here to appreciate that, because stridor is one of the first things that I want to look for the presence of, because it's usually present in both epiglottitis and it's also present in your croup, which is your Laryngotracheobronchitis. Usually epiglottitis is associated with more worsening signs of respiratory distress, and it's usually primarily inspiratory. And then patients who have croup, it can be biphasic, so it can be inspiratory and expiratory, and it's also worse at night. But again, it would sound a little bit like this. All right, so we can really appreciate the way stridor sounds. So that's the critical thing that we need to be able to identify, is the presence of stridor, and as well, is there any signs of other forms of respiratory distress? Are they working really hard to breathe? Is there nasal flaring? Is there intercostal retractions? Are they tripoding? These are all really, really important things to consider. If those things are present, especially stridor in combination with signs of respiratory distress, that's where I want you to think about things like epiglottitis and laryngotracheobronchitis. These can be very, very concerning, especially epiglottitis. This can be a high risk one where patients can go south very, very quickly. So my next question is when we have a patient who presents with stridor, signs of respiratory distress, this becomes a very, very common thing I'm going to kind of bring up. We talked about it in the deep neck infections. We even talked about it a little bit in throat infections, and we'll talk about it in our next lecture coming up soon, upper respiratory tract infections. Is that when a patient presents with persistent stridor, especially at rest, and other signs of respiratory distress, especially in epiglottitis, the most important thing is not saying, all right, dude, I'm going to go ahead and get an x-ray. I'm going to lay them flat. I'm going to get labs. I'm going to take my time. I'm going to look in their mouth, all of these. No. In these scenarios, you will secure the airway and make your diagnosis oftentimes by directly visualizing the epiglottis upon intubation. And that is what I want you guys to remember. The first step in the approach for a patient who has stridor and respiratory distress, especially in a patient like epiglottitis, is to secure the airway, then go through all the other steps that you think that you need to go through. That's the critical thing. But oftentimes during intubation, you make the diagnosis, because I want you to remember this. Epiglottitis is the gold standard of diagnosis is direct visualization of the epiglottis. And guess what you see when you try to intubate someone when you're using a laryngoscope? You see the epiglottis. And that's the key thing here. So that's just, again, a really, really important thing. If a patient with epiglottitis or croup is presenting with signs of respiratory distress, they're hypoxic, put oxygen on them. If they're not ventilating, if you're concerned that their airway is near the point of total obstruction, you need to go forward with intubation. That is the key thing. All right. Let's say that you have time, though, the patient's stable, you're not worried about that right now, you're monitoring their airway. Ask the question, do they have a cough? The reason why is an epiglottitis, it shouldn't really have any kind of cough. It's so painful, and it's not usually going to be presenting with a cough. So that would be really, really important. If they did have a cough, we'll talk about that in a second. There's a very characteristic cough that is suggestive of croup or laryngotracheobronchitis. The other thing I want you to do is not just associate the cough, but look at the clinical findings that suggest epiglottitis. Just because a patient has stridor and they don't cough doesn't mean that they got epiglottitis. So for example, if you got the 3 Ds, so drooling, which is again, usually because there's so much swelling, it's causing pooling of secretions because the epiglottis may be kind of blocking the flow of secretions into the esophagus. If there's dysphagia, and I would even be a little bit more specific, it's not just difficulty, but it's also a lot of pain that comes with swallowing. That's really, really critical. It's just because any kind of food and fluids that's moving across this beefy swollen epiglottis as it tries to move into the esophagus, that's going to cause a lot of pain. And then distress. We already talked about the signs of distress. It's any kind of stridor, tripoding, nasal flaring, intercostal retractions. All of those things really make you think about epiglottitis, or at least some kind of upper airway obstruction. And that's the key. Whenever a patient has an upper airway kind of like obstructive symptom, you want to consider neck x-rays. Is there a foreign body? Is there something else going on? Epiglottitis, you do not need a lateral neck x-ray to obtain the diagnosis. If you do, great. But it's not something that's always done, and it doesn't need to be done, because guess what the gold standard is? It is direct visualization. So when I say obtain a lateral neck x-ray, that can be done. But usually it's being done in combination with kind of ruling out other alternative things and maybe helping to assist if you have any concerns or it's inconclusive of what you're thinking. But if the suspicion is high, you can go to direct visualization. Sometimes a lateral neck x-ray just helps to rule out other kinds of things that could be going on, like a foreign body, like something else. I mean, that's the key thing here. So let's say that I got a lateral neck x-ray. You may see something here. You see this right here. It kind of looks like a person's thumb. We call it a thumbprint sign. And that really is a concerning feature because it tells me that the epiglottis is kind of like super edematous. It's really swollen and it's causing this visible presentation. Just because the thumbprint sign isn't present doesn't mean they ain't got the epiglottitis. If your suspicion remains high despite the absence of a thumbprint sign, you still proceed to direct visualization. That's the goal that I'm trying to get across to you. This is just a helpful kind of test where it may suggest a thumbprint sign, adding some utility, but just because it's not there doesn't mean that they don't have epiglottitis. So that's the key thing here, is to know that this is the gold standard, the direct visualization. It's just the ways that you get to that. For example, in a patient who presented at the top with that stridor, respiratory distress, I'm going to probably just go straight here to intubate them. That's probably going to be the way. And usually these newer ways that we intubate, and I wouldn't say it's new, it's been around for a while, we have cameras on our laryngoscopes and we can actually visualize what this actual epiglottis looks like. And when we do that, it helps us not only to guide where the epiglottis and the cords are, to guide the position and where we're putting our endotracheal tube, but it can visualize the epiglottis. And if I do that and I see visible swelling like this, it's pretty straightforward to say, oh wow, they got this super like erythematous and edematous epiglottis. And you can see the tube kind of running through there. That's the concept that I want you guys to understand. I'd be able to make the diagnosis during the intubation process of securing their airway. All right. Another alternative is you could say that you got that stable patient who's not really, they have maybe a little bit of stridor, they have some drooling, they have some difficulty with, some swallowing and a muffled voice, but they're not tripoding. They're not in any kind of like nasal flaring, intercostal retractions. They're not hypoxic. Their stridor isn't super aggressive and pronounced, etc. You get the point. Maybe I have some time that I can actually do more of a fiber optic way, where I can actually use a fiber optic kind of like cable to go through and visualize the actual larynx. And I'm going to do this while they're awake. I'm not going to intubate them. And I'm going to be able to see visually where that is. And so doing some type of flexible laryngoscopy while they're awake, maybe running that through the nasal area or through the oral cavity, is the best way to be able to run this thing through and say, oh, I can see the epiglottis. I can visualize the epiglottis. And this is what I would see normally. You can see that the epiglottis is not super erythematous. It's not edematous. I can visibly see the cords. This is a nice looking epiglottis. I look over here, it's like day and night. It's like someone who got pumped up with a bunch of gas. This thing is, I ate about 75 Oreo cookies over the past, 5 years. So this is a blimped up epiglottis. It's red, it's edematous. You can even see that there's likely an endotracheal tube or something kind of being placed through this area here. And I can't even see the dang vocal cords. So my anatomy is super blurred. This is an obvious way of being able to identify a patient who has epiglottitis, but you get the point. If you visibly see it, that's the way that you're going to diagnose it. It's just the way that you get to that point. If it's stable enough that they could tolerate you doing flexible laryngoscopy, do it. If they can't, you'll visualize it upon intubation. And that's the key difference here that I want you guys to understand. All right. That's how we get to epiglottitis. So a big thing to take away from it is kind of the symptoms, but with the gold standard being this. This may be done, but it's not the end all be all. All right. When you have a patient who's being intubated, you can try and get some cultures. That's not always done. You don't have to do it, but it can be done. What I would say is because epiglottitis has a risk of being Haemophilus influenza type B, that can seed into the bacteria. That can seed into the bloodstream really quick and it can become bacteremic. So blood cultures are a necessary, because these patients run a high risk of things like pneumonia and meningitis. So you really want to be able to make sure that you're doing those blood cultures to identify that and watching out for the symptoms of things like meningitis and pneumonia, because they're pretty high risk, especially if it's that bacteria, because it's an encapsulated one. Let's say that you have a patient who does have a cough, but we define that cough very specifically. We add in there that it's a barking or a seal-like cough. That's really what helps you to, I'd say, nail down that diagnosis of croup. So a young child who comes in maybe a day or two prior, because again, this is a parainfluenza virus, it usually does kind of spread. So they may have had some nasal congestion, maybe some post-nasal drip, some rhinorrhea, maybe a little bit of a sore throat. Now they're coming in and they have this barking seal-like cough along with stridor. So the big thing here with this one is that barking seal-like cough that's gonna pretty much establish the diagnosis. So you can kind of appreciate that there. So that's the key critical step here, is that when you hear that kind of barking like seal-like cough, and it was actually preceded by a little bit of a stridor, that's the essential thing here. Now, what I think is really important is that with laryngeal infection, so a patient who gets Laryngotracheobronchitis or Croup, it's usually a parainfluenza virus. When you get an infection, you kind of cause this damaged tissue, which creates an opportunity for bacterial to superinfect it. That's not too common. It is relatively rare, but I think one of the key things is that Croup should respond relatively well, unless you're at a very, very late stage, which we talk about in a little bit, called the Wesley score. As you get towards those later stages, the responses to things like dexamethasone and nebulized racemic epinephrine you may require more frequent doses, but they usually have an improvement to some degree. When it gets to a point where it's bacterial infection and there's purulent pus-like membranes that are forming, you can reduce edema, but if the pus and purulent membrane's still there, the obstruction still exists. And that's not going to get any better. So that's a really important point. So patients who do respond, at least even if it's minimally, or they have improvement with dexamethasone and racemic epinephrine, that really helps me to have more of a supportive diagnosis of truly Croup. If they have a poor response or very little or almost no response to dexamethasone or racemic epi, and they're having a productive cough, they look really, really toxic appearing. Their fever went from low grade to very, very high grade. White blood cell counts really high. I'm starting to think more of a bacterial superinfection, especially something like bacterial tracheitis. Here's where I want you guys to remember an important point. When a patient has Croup, the diagnosis ends right here. At the point of once you have the stridor, that barking seal-like cough, they respond to racemic epi and dexamethasone, or just dexamethasone. You're kind of at that point where it's likely just Croup. We do not need x-rays. You don't need to get an AP neck x-ray for Croup. If you do it, it's because you're not sure that if there's something else going on. It's kind of like epiglottitis. You don't need the lateral neck x-ray to make the diagnosis. It just may help you to rule something else out and find something suspicious of it. Croup is the same concept. It's a clinical diagnosis. We can stop. We don't need to get an x-ray. If you get an x-ray, it's because you think that they may have something like bacterial tracheitis. You may think that they have something like a foreign body. Something else is going on. But if you did, what you would find is you'd probably find a normal tracheal air column. As you can see here, the tracheal air column is not normal until you get up to the subglottic area of the larynx. What do you notice? You see how this thing starts to taper out? This is called a steeple sign. And the steeple sign is very, very common in patients who have Laryngotracheobronchitis, Croup. But again, here's the important thing. It doesn't need to be done in order to make the diagnosis. It's a clinical diagnosis. The thing also is that steeple signs can be present in bacterial tracheitis because it is narrowing of their laryngo, their subglottic larynx, and also their trachea, right? It's just now it's a purulent membrane. And that purulent membrane, sometimes you may see it and sometimes you won't. But especially, I think, on lateral views, if we did, we would actually see that they would have this kind of purulent material here. Sometimes they call it like a shaggy tracheal borders or regular tracheal borders. Sometimes radiologists will call this a candle dripping sign because it looks like a candle's dripping in this scenario. Either way, there's something else besides just generalized edema that's present. That's the pus. That's the purulent material from bacterial tracheitis. But again, it goes back to the point, is this the definitive way that I would make the diagnosis? No, but it definitely helps me to at least say it ain't Croup. In this case, I'm worried about bacterial tracheitis. What do I then do? A bronchoscopy. That's what you have to do. So if I see this, all right, it definitely supports me saying this isn't definitely not Croup. It's something else. I need to then go for it, especially if they have fever, productive cough, they look really sick, they're not responding to the standard therapies for Croup. That's when I'm going to get the bronch. The bronch is the most beneficial because it'll visualize and also aid in therapeutic necessities. So when you do a bronchoscopy, you're going to run this down, you're going to get this into the larynx and into the trachea. You'll visualize this pus and this purulent membrane that's going to be present. And when you do that, there's the diagnosis, but what else does it help you to do? Use the opportunity to scrape and suction and lavage and get all that stuff out, because that's the critical thing that has to happen. And also, you can obtain some cultures, because this is usually some nasty pathogens like Staphylococcus aureus that causes things like this. All right? So that's the key critical thing that I want you guys to take away from this. If you do not have any of these things, guess what it probably is? It's probably laryngitis. Because usually in these patients, what's the most common clinical manifestation for laryngitis? It's usually like hoarseness of their voice. And oftentimes laryngitis by itself isn't always super common. It's usually associated with like a viral infection of other parts of the respiratory tract. In other words, they have a little bit of nasal congestion, maybe a little bit of post-nasal drip. They got a sore throat, and then they got a hoarseness of the voice. So it can be localized, but oftentimes it's usually unspecified, and it's a part of a general common cold. But either way, laryngitis is pretty much one of those where you don't have to be super worried. It's not going to cause so much swelling and obstruction of the airway that you have to be concerned with it. So that's the key thing, is just looking for that hoarseness, those upper respiratory tract infection symptoms, and you likely have the diagnosis. What I would add on here is patients who have laryngitis for more than 3 weeks, persistent symptoms like that, you got to then start thinking about something concerning, something like structurally present, a chronic issue like malignancy. That's when I would go to laryngoscopy. But otherwise, this is a clinical diagnosis. Wipe your hands of it, move on. All right. We talked a lot about the diagnostic approach, but then when it comes to treatment, what do? A lot of this goes back to the airway, right? So for epiglottitis, if I said, what is the most important thing for a patient who is in respiratory distress or has signs of severe stridor? It's airway management. Airway management is an umbrella term. It can look a lot of different ways. For someone who's just minorly hypoxic, but they're not in a lot of distress, you can put on nasal cannula. Sometimes if they're a little bit more hypoxic, and I think one of the benefits of this next therapy called high flow nasal cannula is that you can kind of humidify the air. And you can also give them 100% oxygen, and you can push a lot of air into their airway. So usually this is for more of the mild cases. It's more for comfort. This one is that they're pretty hypoxic, and we want to help with a mucolytic kind of effect, which is kind of beneficial in things like bacterial tracheitis or other kinds of mucus containing scenarios. It really helps to kind of allow for that ability to cough up some of those really nasty secretions. And it's just also way easier and more kind of just overall comfort. When you give these high flow rates and high amounts of oxygen, humidifying that air makes it easier for the patient to breathe. So oftentimes in patients like who have epiglottitis, we can give things like that maybe as a way of just stabilizing them before we have to intubate them. And in patients who have things like croup, especially if it's hypoxic, they're having impending respiratory failure, we may start off with this and then really just be prepared to have to intubate them. So this is usually a way of being able to help. It's kind of just giving them time. Hopefully we can kind of monitor them. We don't have to intubate them, making sure that we're giving them a good flow. It does help a little bit with ventilation. It helps very minorly with the positive pressure, helps with mucolytics, and it really helps with oxygenation. So that's the key. But if we're getting to a point where we're struggling to ventilate, oxygenate, and maintain secretions, and the patient's starting to have difficulty maintaining it, or they're really struggling to breathe despite those things, or we're getting to a point of a near total airway obstruction, that's when endotracheal tube intubation is going to be necessary. So that would be kind of the escalation step. The worst case scenario is when we got to go to the crike. When we have to cut through that cricothyroid membrane and install a tube, that's pretty aggressive. And we want to only save those for rescue scenarios. And that's a concept that I want you to remember, okay? That's a general blanket umbrella term. With epiglottitis, you may kind of progress through these. It's very rare for that to happen in the remainder of the laryngeal infections like croup. Bacterial tracheitis almost always ends up resulting in intubation, but it's not one of those where you usually have to get, a crike. But either way, you get the point. This is the way that we kind of manage them. And so it's just making the decision of what do we need to do. Is it more for just giving a little bit of oxygen, making them feel comfortable? Do we really have to oxygenate them? Do we have to give them humidified air to help with that mucolytic effect? Do we have to give them a little bit of ventilation? Is that the key in just kind of hopefully not having an intubation? intubate them? Are we near the point where we're struggling to ventilate them? We're not oxygenating them enough. The secretions aren't being properly controlled. We got to intubate them. Oh, we're in a world of hurt now. We have waited way too long. We got to crike them. That's the concept I want you to think about. All right. The other thing that's necessary for these patients is antibiotic. Once we secure their airway, then we go ahead and we start antibiotics, or if we're monitoring the airway, we kind of do that, and then we start antibiotics. Ceftriaxone is going to be the go-to. The reason why ceftriaxone is going to cover your Haemophilus influenza type B, it's going to cover your strep, and it can cover methicillin-sensitive Staphylococcus aureus. It's not going to be great if you have MRSA. So if the patient has MRSA risk factors, that's why I added in the plus or minus vancomycin. You're only going to add that on if there's a concern for MRSA. All right, the next thing is dexamethasone. Dexamethasone is good for reducing overall edema. If the epiglottis is swollen and we can get some of that overall like vasogenic edema reduced, dexamethasone will come in and actually help. But it takes some time. It's not going to be an immediate thing. You can give a bolus first up, pretty good dose, and then after that you probably stay on a maintenance dose until we can actually kind of really have some improvement. A lot of the times if we have to intubate them and we're kind of give them these scheduled doses, so eventually we can reduce a lot of that edema enough that we can get a cuff leak and then go ahead and extubate. All right, so the way I want you to think about epiglottitis is what's the stability factor? Is there distress? Okay, there's not. You got time then. Monitor, antibiotics, steroids. You got respiratory distress, you airway secure, and then you start with the actual antibiotics and the steroids. That's what I want you to take away from that. With Laryngotracheobronchitis, also known as Croup, again, airway management is first line. You rarely ever have to intubate these patients. There's some that you do, and it's almost unnecessary to do this with a cricothyrotomy. Dexamethasone is really the heavy hitter here. This is the workhorse for laryngotracheobronchitis. It's subglottic edema caused by a virus. If you can reduce that vasogenic edema with a long-lasting kind of effect of that steroid, it's going to be the most beneficial. The question is when do I need to add in other things? Because a patient who's mild, I can use dexamethasone. It takes a little bit longer to work, but it's long-lasting. So if I got time, great. But in a patient who doesn't have a lot of time, they're coming in, they're breathing fast, they have severe amount of stridor, they're kind of struggling, and I need to then say, what do I do to get that airway to at least give me a little bit less edema to make some space so I don't have to do things like high flow, I don't have to intubate them. That's where something like nebulized racemic epinephrine comes in. Let me just take a second to explain what I mean. This is a patient who has a lot of subglottic edema. When you give these drugs, especially things like dexamethasone, that's long acting. It's going to work for a long time, but it has a while for that onset to really reach its peak effect. With nebulized racemic epinephrine, that thing is very quick. It's going to act super fast, but it doesn't last as long. So in patients who are more in that moderate to severe presentation, Wesley scores that are usually 3 and above, we want to give them dexamethasone, let that do its thing, which is going to take some time, and then give them the racemic epinephrine to bridge them. Give them that time to where we can allow the dexamethasone to do its work. With the goal of, see how that disappeared? We got rid of that. We got rid of that swelling. That's the goal. And so that's the key thing that we want to try to do here so that we don't have to go to things like oxygenation and intubation. But if we need to, we will. So that's where I want you to think about Croup is the patient who comes in who's very mild. We do this based upon their Wesley score. You don't need to memorize this. Usually it's just kind of knowing that if it's a lower score, less than 2 or equal to it, it probably means that they don't have a lot of severe stridor. They probably just have more of that barking seal-like cough. There are no really signs of respiratory distress. This is a patient you can probably just do dexamethasone and you'll be okay. When you get to the more moderate to severe group where the Wesley score is like 3 or above, this means that the patient's having some pretty significant stridor. They're having signs of respiratory distress. They're having some concerning features. They're not at the point where they're like cyanotic. They're not hypoxic. They're not to the point where you're worried about them ventilating, where they have almost a quiet, we call it a quiet croup, a quiet chest, where there's so much swelling that it's almost completely obstructed, where almost no airflow is moving. And that's impending respiratory failure. They're going to code. And this is a patient they're working a little bit hard. Maybe they're a little bit tachypnic. Maybe they have a little bit of nasal, retractions and stuff like that. Nothing severe, but the main thing is that the stridor's pretty good. They have a little bit of an increase in respiratory rate. Their cough isn't that great. These are the things where I'd say get the nebulized racemic epi to help to reduce that kind of swelling, improve the stridor, improve the cough, improve some of the airway obstruction, and give it time. If during that time frame, any point in time, the patient shows hypoxia, you should be crapping your Huggies, because hypoxia for a Croup patient means that you're getting really towards the late stages. if they're showing any signs of severe respiratory distress, they're cyanotic, they're really, really working hard to breathe, or I'd say the key thing is that they're not really moving much air, you're really getting late in the process. That's when we add on. So usually the only time we add on oxygen is if they're hypoxic. So an SpO2 is less than 92%. The only time that we really want to go ahead and do things like high flow or intubate them is if they're in respiratory distress. You're still going to be doing these things. It's just which one takes priority. So if a patient came in and they're not showing hypoxia, impending respiratory failure, I can just do this. But if they have hypoxia, they have signs of impending respiratory failure, guess what I'm doing? I'm airway management first, which is usually you put them on this high flow nasal cannula and you probably give them humidified oxygen. Sometimes it can be that, right? And then just be prepared to intubate them. Right? And then while you're doing that, that's kind of supporting the hypoxia. That's giving them a little bit of oxygenation, maybe a little bit of ventilation. And then the goal is to allow for that to kind of bridge them while you're allowing that subglottic edema to be addressed with these. The hopeful goal is to never have to intubate. All right. But that's the way I want you guys to think about croup. All right. Bacterial tracheitis, pretty rare. But if this does come about, it's usually a patient who came in with Laryngotracheobronchitis. And all of a sudden, maybe a couple days, week later, they come in high fever, worsening stridor, very productive cough, hypoxic, they look toxic. This is a patient where airway is almost always needed. I'm not kidding. I think the research showed that like 50+% of these patients almost always end up intubated. So that's a pretty large amount. Obviously, antibiotics are key. And because Staphylococcus aureus is a really big concern, we definitely want to always consider adding on vancomycin for this one. So usually it's a dual antibiotic to cover things like strep and again, to cover things like MRSA. And the next thing is always bronchoscopy. With these, you have to consider bronchoscopy because they have this purulent, sticky material and it can be a pretty hardcore membrane. You might have to go in and actually kind of rip and debride that part. You may have to suction it, aspirate it, because again, it's going to keep plugging their airway. Oftentimes these patients get intubated and they keep clogging their endotracheal tube and they keep getting these high pressure alarms and we have to suction. Sometimes it may plug up the entire bronchus that they get severe, like we call it like a mucus plug where it causes almost complete whiteout or atelectasis of the affected lung. And then you have to go in and bronch them. So bronchoscopy is usually kind of a very important focal point here to help to suction out those secretions, remove any kind of like membranes that may be there from the bacteria. And again, also just really help for source control. So again, for this patient, the way I want you to think about this, which is it's almost really ever not they're almost always in respiratory distress. You may be able to get away with just some antibiotics. Almost never the case. Usually for these patients, they have to get tubed. You're going to have them on antibiotics and you're likely going to be doing a bronch. All right. That's the way I want you to think about this patient. The last one to remember is laryngitis. There is almost no need to do any kind of airway management for this patient. There's nothing really specific that really goes into this. There's no antibiotics. There's no steroids. You can consider steroids sometimes, but oftentimes, for more often than not, it's supportive care. And what do I mean by that? If they're in pain, analgesics. If they are kind of, because of the conditions in which we have from viral upper respiratory tract infections, hydration is always key, rest is always key, voice rest is also really important so that you don't worsen that inflammation. But oftentimes this will go away on its own with just kind of like watchful waiting and reassurance. All right. Wow, that was a nice lecture on laryngeal infections. I really hope that you guys enjoyed. I hope at the end of it, it makes sense. You kind of know what to do, when to do it, why you do it, and then I think that makes you a better clinician. I hope that it helped you guys, and if it really did, some ways that you can show that support, again, is just hitting the like button, comment down in the comment section, subscribing. And again, you want some more information, things I think that always help with spaced repetition is when you watch a video, it's easy to forget things. So what do? We watch it again. Well, what if there's other ways? What if you could follow along with me during the actual video? Draw things out. I think that may be beneficial. What if you had notes that go back and kind of recap something that you don't want to watch the whole video for? We got that. What if you want quick flashcards as reminders of big high yield facts that were a part of the lecture? We got that. What if you want a quiz to really see if you understand it? We got that. So if you are interested in those things, go check out the website. But man, I love you guys. I thank you guys. And as always, my friends, until next time.